Take your phone.
फीवर तो नहीं, फीवर नहीं ना?
Hello, Rakesh ji. Ojas Poddar and Abhishek Ghosh will be answering today. Mr. Dr. Ojas, can you please?
Yes, sir. Switch on the audio, video, sir. Yes.
Yeah, I'm Dr. Achin. I will be presenting today. Gaurang Shah sir will join soon. Okay.
Yes, sir.
Okay, thanks.
Abhishek, you are answering?
Yes, sir. Good evening, sir.
Good evening. Who else?
Good evening, sir. So Ojas here, sir.
Ojas. Okay.
Yes, sir. Yes, sir.
Abhishek, what happened? तेरा हुआ?
हाँ सर, हाँ हो गया सर, उनसे बात हुआ आज सुबह, मेरा हो गया, ही कंफर्म सर.
Good, very good.
Yes,
So
sir.
ticket,
Thank you,
stuff,
sir.
everything.
हाँ, he'll send it, sir, shortly. He said. Thank you so much, sir. Thank you so much.
We'll wait for 5 minutes, 5-7 minutes. Let.
Okay, sir.
Achin, just ask Dr. Hiren when is he joining. Otherwise, in
Yes, sir,
another
I'll
2-3
ask.
minutes.
Yes. So Hiren sir is not picking up call. I messaged him.
Achin, Hiren's case is over, no?
Yes, sir, case was over. Sir has already left the hospital, but he is not picking up call. I have left a message.
Can you just find out about Pankaj Maheshwari?
Tabi madam has messaged me. Maheshwari sir is stuck in an emergency, so he won't be able to join.
Okay. So we will just wait for 2-3 minutes and start. Okay.
Okay, sir. Oh, yes.
Sachin, okay, we can start now.
Okay, so we'll start.
So Abhishek and Ojas,
Yes.
even though there may be a change in the pattern, still the long case is always they ask about the history. So in this case also, we will not go too much in detail of the history because normally we are doing it regularly. But you must know the salient feature so that we can go a little faster for investigations and the management part,
Okay.
right?
Okay.
And you should be very coherent and very systematic. Okay, don't answer haphazardly.
Yes,
That's
sir.
more. Your thoughts must be very clear. Fine. Okay.
Yes.
Fine.
Yes.
Okay. Go ahead.
So I'm starting.
Yeah.
A lady, 41 years of age, Hindu by religion, housewife, resident of Pune, came with complaints of pervaginal discharge since 7 months.
Okay. So just let us start. When the patient is that per vaginal discharge, so
Yes,
what
sir.
you understand by discharge?
So regarding the discharge, I will have to first ask the patient since when has the discharge started, the onset of this discharge, whether what is the quantity, how much pad soakage is there, what is the color and the smell associated with the discharge. Uh, then I will also like to inquire about whether there is any associated her menstrual history, whether the menses have been regular and whether current menstrual cycles, and then any history of fever, and this history I will first like to inquire and then proceed, sir.
Okay. You want to add anything?
Sir, first of all, I would like to characterize the discharge first of all by asking what kind of discharge is it? She's having it since 7 months. So is it like a watery discharge? Is it pus discharge? Is it blood? Is it like what is it first of all? And thereafter, sir, what is the onset, the duration, the progress? I will classify my history in such a way that I will characterize the discharge first, then the etiologies, and then the associated complications with it. So the history of PV discharge, sir, I will ask onset, duration, progress, the amount of discharge it is that is coming, judging by the number of pads that she's been using. Is it continuous or is it intermittent kind of discharge, sir? Is there what is the voiding pattern associated with the discharge? Is it affected? Is it some? Are there some lower unit tract symptoms? Is there any dysuria associated with the discharge? Any positional association with the discharge if it increases or decreases with change in position? Any is there any associated smell with the discharge? Is it foul smelling? And other than that, sir, then I will try to elicit the history of associated complaints in the form of fever, foul smell with the discharge, any previous obstetric history which has led to this discharge in the past 7 months, the complete obstetric history in the form of the delivery, the kind of delivery, abdominal, vaginal, whether forceps were used or not, is there any history of LSCS or not? And other than that, any history of trauma I would want to ask, sir. Of course, menstrual cycle I would want to find out. But history of trauma also, sir. What kind of trauma? Was there any penetrating injury? Or was there any sexual trauma? Was there any pelvic trauma associated with that leak? And other than that, sir, I would like to inquire about history of malignancy in the form of, sir, if it is frank blood in the form of discharge. So is she having loss of weight and appetite associated with the discharge with or without a lump in the abdomen? Any history of associated radiotherapy that she has underwent? for that discharge? I mean, any associated malignancy history, sir? Yes, sir. I would like to proceed like this, sir.
Okay.
I think you have asked all the questions very well. Yeah.
Yes.
Like last time I had pointed out that you must go systematic. One, go with the discharge. Second, questions related to discharge, which you have done very well this time. I must appreciate that.
Thank you, sir.
The only thing is that I would want you to ask about, surgical history separately, because many times VVFs are iatrogenic. So you asked about you asked about obstetric history, you asked about malignancy, but you can ask about treatment history or surgical history, after which whether this has started. You can be specific, because nowadays we see many of the VVF which are iatrogenic. That is it.
Right.
Fine. Okay.
Sir was saying something. Sorry.
Yeah. No. I was going to tell him the same thing, that you have done very systematically.
Yes,
So
sir.
let us go ahead with this.
Yes, sir.
Okay. I think
Patient was apparently asymptomatic 8 months back when 45 days after emergency laparotomy for abruptio placenta, patient developed pervaginal discharge, clear, watery in consistency, continuous dribbling, non-foul smelling, unrelated to passing of urine, with soakage of 10 to 15 sanitary pads per day associated with decreased urine output.
okay. Go ahead.
Then sir, negative history, sir. Immediate past surgery, sir. History of emergency laparotomy for abruptio placenta done 8 months back. Sir, specific surgery for that laparotomy was not there. Only patient knew hysterectomy was not done, and peroperatively SPC was done. And till then she is on SPC. She underwent cystoscopy with bilateral degesting 45 days prior to the after the emergency laparotomy, and then went for definitive management of VVF later after 1 month, and SPC was removed after 6 weeks, but the passage of pervaginal discharge started, so SPC was reinserted.
Okay. So further history.
For the negative issue, sir, no history of fever, burning, micturition, no history of abdominal pain, no history of hematuria, no history of pyuria, no history of any radiation, no history of any trauma. Iatrogenic surgical history relevant history I've already told. No history of facial puffiness, lower limb edema, exertional dyspnea.
Okay. So Ojas, what are the different types of discharges you will come across?
In case of vaginal discharge, it can be thick consistency discharge, which is related to infections. Then it can be
What are the infections you come across?
so mainly it will be sexually transmitted infections. It could be related to gonorrhea. It could be gonorrhea, then chlamydia, and syphilis, and
How often
fungal
now
infections.
Beta, you can say
Yes, sir.
sexually transmitted diseases,
Yes, sir.
bacterial as well as fungal.
Fungal infections. Okay. Yes, sir.
fungal, the discharges can be secondary to, mainly it can be because of bacterial sexually transmitted diseases. Correct?
Yes, sir.
It can be flagellate,
Yes, sir.
it can be fungal, or it can be because of chlamydial infection.
Yes, sir.
So these are the common, and the same thing can be transmitted back into the partner. So when the male comes to you, you have to
Yes, sir.
treat all these things. Okay.
Both of them. Yes, sir.
Yeah. Then this is one discharge. Second.
Then bloody
Sir
discharge.
was asking about syphilis. Do you
Uh,
see
Syphilis,
discharge
I
in
think it
yeah.
gets
Sir,
discharged.
less commonly. Sir, actually, there will be more of lesions rather than discharge. Yes, sir.
Yeah. Correct.
Yes, sir.
You have to say that they are very well demarcated lesions.
Yes, sir.
There is no discharge. There is no pain. Patient is absolutely comfortable with it, and sometimes may not seek treatment, and they may disappear in 14 days.
Yes, sir.
And right now, the trend of syphilis has changed.
Yes, sir.
It is seen more in homosexuals with rectal anal intercourse.
Yes,
You
sir.
must be aware, and you should say that.
Yes, sir.
Not related to this case. Generally, I'm saying.
Yes, sir. Yes, sir.
Okay.
Then, yes, sir. Second could be bloody discharge. Bloody discharge can be related to, we have to rule out underlying malignancy. Uterine or any cervical malignancy. That is for bloody discharge. Then thin watery consistency discharge, which could be related to urogenital fistulas. It could be contamination. It could be just it could be menses. She's mainly in the perimenopausal age group, so we have to know about the menstrual history. So it can be menstrual discharge as well. And yes, sir, this four, sir.
No,
So
nothing
examiner
else?
may also ask that
Yes, sir.
is this discharge or
What
what
else?
do you think? It is urine.
If it
Because
is a
actually-
urine, what else it
Yes,
can
sir.
be? It can be communication with what?
So it can be in urogenital fistulas, there is a urine discharge. So it can be either fistulas higher up, in which it can be vesico-uterine fistulas. Then it can be vesico-vaginal fistulas, urethrovaginal fistulas. In these cases, the patient will have a thin watery discharge, which could be related to a iatrogenic history or obstetric history, which has to be inquired upon, sir.
So uretrovaginal fistula will not give rise to watery discharge.
Uretrovaginal fistula can also give rise to, yes, sir, uretrovaginal, vesicovaginal, and urethrovaginal.
And if it is a intestinovaginal fistula, then
So then it will be a foul-smelling feculent discharge.
why you are forgetting about it?
Yes, sir. So that can also be a classification in the discharges. Yes, sir, the feculent discharge.
So Abhishek, let us talk about the thing, vesicovaginal fistula or uretrovaginal fistula, whatever it is. So in that, how can you classify? Like, that depending upon the micturition and type of discharge patient has. Suppose if the patient has got only pervaginal discharge, urine coming out,
Yes,
what
sir.
are the possibilities?
Sir, only pervaginal, if urine is coming out, sir, it can be a vesicovaginal fistula, it can be uretrovaginal fistula, sir, or a urethrovaginal fistula.
Only
And-
pervaginal. Patient is not passing per urethra. 4 millimeter fistula will give rise to vesicovaginal fistula, will give rise to only pervaginal urination.
Sir is asking high output fistula.
Yes, sir.
If it is a small uretrovaginal fistula, it can be that patient has normal voiding in the middle because bladder is getting filled with the opposite kidney.
Yes, sir.
Yes, sir. Yes, sir.
Okay, so you have to think about that.
Right.
Sir
So
is saying
either it
suppose
is
there
a
was a
high-
large vesicovaginal fistula, it will keep on emptying, na?
Yes, sir.
Like
There will
in
be
this case, they have put a SPC. Do you think SPC will heal that? If SPC was healing the fistulas, why we would be doing surgeries?
Yes, sir. Yes, sir.
Yes, sir.
So number one is a high output fistula, the big fistula, more than 5 millimeters. Correct? So
Yes,
this is
yes, sir.
number one. Second thing is bilateral uretic fistula. Correct?
Yes, sir.
No. Yes, sir. Yes, sir.
Or it is a solitary kidney with a uretic fistula.
Uretric fistula. Yes, sir.
Right? So these are the cases where you will have no normal urination.
Like sir said, sometimes when these are iatrogenic, it can happen that one side they've ligated the ureter and one side they've caused the thermal injury.
Yes, sir. Yes, sir.
Okay.
Understood. And the last is, as he said, one side you have ligated and one side you have injured the ureter. So
Yes, sir.
nothing is coming into the bladder. So these are the causes where you have got
No
a high
voiding,
output
yes.
vaginal
Fistula.
fistula.
Yes,
So now
sir.
if the patient says that in between she is passing urine and otherwise continuously she is leaking from vagina. So what is the cause?
So vesicovaginal fistulas and urethrovaginal fistulas, or a single side uretrovaginal fistulas.
So since we are talking about these injuries,
Yes, sir.
It should be only one side uretrovaginal or a uretrovaginal fistula. So patient is passing, voiding normally, and also at the same time there is a continuous leakage of urine.
Yes, sir.
Correct?
Yes, sir.
Fine. Suppose patient says that no urine is coming after surgery. What are the possibilities?
It could be both the ureters have been transected and or a solitary kidney in which the ureter has been transected, so there will be urinary ascites in that case.
Maybe, but usually it is bilateral, ya to solitary kidney ureteric ligation, and you
Yes,
have
sir.
not cut.
Okay.
Understood?
Yes, sir.
Okay.
So because we are
Now-
talking about iatrogenic, sir, one question for them: that why are these iatrogenic injuries so common? Why the gynecologists usually have a problem with this? Can you enumerate some causes which are likely in such cases there is likelihood of injury?
So one is an underlying malignancy with dense adhesions. Previous multiple surgeries, laparotomies in which there are post-op adhesions. Then post-radiation.
So again, beta, I would divide it into obstetric emergencies or injuries and malignancy. Okay. So
Yes,
whenever you divide the causes, you will not miss out any causes. Okay. So usually obstetric injuries, if there is a prolonged labor or some complication, like here there was some eclampsia or whatever,
Yes, sir.
an emergency laparotomy, something like that. Then the other injuries, where there are hysterectomies. Many times they are doing hysterectomies. So what
Yes,
is the
sir.
meaning of water crosses under the bridge?
So the ureter goes under the uterine artery. That is water under the
Correct.
bridge.
So that is
Yes.
why when they are doing hysterectomy and they are ligating, sometimes they fail to identify the ureters. Okay.
Yes, sir.
And third, in bad cases where there is malignancy, everything is stuck and like that. So if you divide your answer whenever you do classification, you will never
Yes, sir.
miss out the causes. Okay.
Yes, sir. Yes, sir.
Good.
Fine. Go ahead. Anything else, Sachin?
Sir, only history, past history, everything is there.
Yeah, finish it. Finish
Yes.
the history.
Past history, no history of any diabetes, mellitus, hypertension, ischemic heart disease. History of previous surgical details I have already mentioned. Family history, presently nothing contributory. Personal history, nothing specific, sir. Bladder is a species already in situ, it's draining presently. And obstetric history, the patient already has one child, a boy, with a history of normal delivery. 14 years is the age of the boy.
Fine. So what was the reason of not doing a hysterectomy? Is a hysterectomy indicated? Rojas? What was the case?
Sir, the family may not be complete, so that has to be that must have been discussed with the patient that she must be desirous of more children. So that might be one case that hysterectomy was not done. So
Yeah, so she has denied. Or
That is very good. Plus, second cause is that you may have not taken consent because
yes,
you've
sir.
gone in an emergency.
Yes, sir.
So you have to think of that also.
Yes, sir.
so what are the different types? Abruptia?
It's sure. So I don't know, sir.
Abhishek?
Abruption.
Sir, I'm not aware, sir.
It can happen that you are not knowing, but it would be nice to know because sir is right in asking this question. Whenever
sir.
it is related to obstetrics, they may go one step further to see whether you know it or not.
Yes, sir.
So, like gynec people say that we don't know about urology, you shouldn't say that. You must know because the uterus, vagina are related to very close to the bladder. So, relations and applied indications. So, this is an applied indication wherein this abruptio. So, you can just find out what are the types and you may not know the
Yes,
details
sir.
of that. Okay.
Achin, Achin, mind is knowing. Achin, you know, you can answer.
No, sir, I've forgotten.
Okay, fine. Then go ahead.
Yes. Sir, general examination, sir. Patient is conscious,
Okay.
cooperative, very wanted to time, place, and person. Moderately built and nourished. Pulse is 80 beats per minute. BP 110/80. Respiratory rate is 20 cycles per minute. Afebrile. SpO2 is 98% on room air. BMI is 29 kilogram per meter square. Karnowski score is 80. No evidence of pilorectal cyanosis, clubbing, lymphadenopathy, edema. Head to toe in spine examination is grossly normal.
Okay.
Local examination for umbilical is centrally placed, all coordinates moving equally with respiration. Previous midline laparotomy, healed scar present, no sinuses, engorged veins. And number 16 SPC Foley is in situ. Palpation, there is no localized of temperature or tenderness. Percussion, tympanic node present all over the abdomen. Expulsion normal, bowel sounds present. All the systems are normal. Sir.
Okay, fine. So just now you want to do which examination?
So I would like to do. I like to take the consent of the patient and do a per speculum examination. First, I look to do a local examination of the perennial region to see first inspect the pads. What is the smell and what is the consistency of the discharge. After that, I will examine the local region whether any signs of perennial irritation or itching is there or any redness is there. I would like to examine the perineum, in which I will look at any perineum as well as the thighs and the lower abdomen. I will look for scars and I will look for any lesions over the thigh and in the perineal region and the labial region. Then I will inspect the urethral meatus and the vagina. Vaginal examination would be carried out with a speculum to note for the discharge, the location from where the discharge is coming, and any abnormal ostia or anything which can be seen. Then also, if I am suspecting in this patient, she has a history that she has undergone a VVF repair, and now she is having again a discharge. I will like to before examining the patient, I would have liked to give pyridium to the patient so that I could do a swab test, a 3 swab test for this patient to first to examine from where the discharge is coming. In case of 3 swab test, after first locating the from where the discharge is coming, I will first do a catheter insertion and fill the bladder with methylene blue, and I will place 3 gauze pieces into the 3 sponges into the vagina, and
You
then
will put the 3 gauze, like, just
yes,
first
sir.
you will
Yes.
put 3 gauze pieces, or first you'll put the methylene blue?
So first I will put 3 gauze pieces, then sir methylene blue.
So whenever you're talking about a test, first you should describe how the test is done. Second is what is the relevance, and third is what are the fallacies. Now, for example, in this case, it's a high output fistula.
Yes, sir.
So, you know,
So the test, 3 swab test is done to determine the location of the vesicle, the location of the urogenital fistula. It is done in that the patient is given pyridium so as to get the color of the urine as yellowish orange, and so initially after inserting 3 swabs into the vagina, we then fill the bladder with methylene blue, and after some time we remove the sponges. If the uppermost vaginal pack is soaked with
No,
yellowish
again,
orange,
do you
yes, sir.
empty the bladder or not?
Initially, yes, we would empty the bladder. Yes, sir.
Unless and until you
Yes,
empty
I
the
would have-
bladder, what will happen?
Yes, sir.
After putting methylene blue, after some time, you have to empty the bladder.
Yes, sir. Yes, sir. We have to empty the bladder.
Those pieces. Otherwise, again, you will not get the right result.
Yes, sir.
secondly, with Ojas and Abhishek, both of you should have used your mind. In the history, Achin told us patient has bilateral BJs which were changed,
Yes, sir.
isn't it? So one
Yes,
more
sir.
thing that it should strike a bell. With the DJ, even if sometimes there's a uretrovaginal fistula, it may stop.
It
So
may
again,
stop. Yes, sir. Yes, sir.
again, fallacy of the test or limitations of the test. Okay.
Yes, sir. Yes, sir.
So you will first empty the bladder and then you remove the gauze pieces. Okay, now what is the
Yes.
inference?
So if the uppermost gauze is soaked with yellowish orange dye, it indicates a uretrovaginal fistula. If the middle gauze sponge is soaked with methylene blue, it indicates a vesicovaginal fistula. Whereas if the lowermost gauze piece is soaked with a dye, it indicates it's a urethrovaginal fistula. If only the last one is soaked. But the fallacies are that in case of high output fistula, all 3 might be stained with methylene blue, and also even if the lowermost 2 gauze pieces are soaked, that also can be in cases of high output fistula.
Fine. Okay. So what else you want to know?
Then I will also
That is correct.
yes, sir. Then I will
You'll
examine
do
the
how will
Yes,
you
sir.
do per vaginal examination? You'll put a speculum and what else?
when I put a speculum, I will like to see for any induration or any abnormal ostia from where I can see any urine leakage. I will also like to rule out any underlying malignancy, any growth or mass.
So you'll
I
put
will
only speculum or you'll use some other instrument also? Abhishek?
Sir, first of all, I would complete my inspection, sir. I would inspect the labial folds. I would inspect the mucosa around the external urethral meatus and the vagina, sir. I would actually inspect the skin of the perineum, sir, whether there are excoriation or not. Then I would do a speculum examination, sir, to find out, sir, first to find out if I can see the site of the leakage, sir. What is the site of the leakage? What is, if there is a fistula, I can see what is the number of the fistula, what is the location of the
So my
fistula.
question is very specific. You will use only speculum or you will use something else also?
Only speculum.
Only speculum? Anterior vaginal wall retractor you will not use?
Okay, yes, sir.
okay, sir.
Otherwise it becomes very difficult. If you,
Yes, sir.
you understand?
Yes,
You
Yes,
have
sir.
to see it properly. And you must have a proper light.
Yes, sir.
Otherwise it becomes again very difficult to see a small fistula. Fine.
Yes, sir.
Okay. So you will try to see the fistula. Then
yes, sir. Sir, try to characterize the fistula, whether it is single, whether it is multiple. What is the? Is there any scarring associated? What is the condition of the mucosa surrounding the fistula? Is it indurated, tender? Is there scarring? What is the location of the fistula? Is it midline or is it like skewed to either of the sides? And other than that, sir, condition of, what is the condition of the vagina? Is it capacious or sir, is it looks reduced in size? And other than that, is there any pooling? Is there any pooling of urine in the vagina? Also, sir, I would want to do the cuff test here, sir. I would ask the patient to cuff and see whether there is discharge coming in the vagina or not. And yes, sir. Yes, sir.
why you want to see how often? Number one, how often you can see the fistula? Number one. Number two means you can locate the fistula. Number two, how often you can find out there is one fistula or multiple fistula on per vaginal examination. So only when the fistula is low, it
Yes,
becomes
sir.
easier to find out. But if it is a high fistula, many a times because there is so much of congestion around that in the full suture line, it becomes when if the continuously urine is leaking, you may not be able to see it. So almost you can say that more than 50% time you are not able to locate exactly. And if it is a very high, your finger cannot reach that. Okay.
So you will also talk to the patient that right now you're doing the examination, but you may need an examination under anesthesia along with the cystoscopy.
Yes, sir.
Yes, sir.
That will complete that may be a separate procedure from your main procedure.
Yes,
Because
sir.
now that the patient has had a failure, has come back, blah blah blah, with all the surgical history, you don't know what is the condition of the bladder.
Yes, sir.
Yes, sir.
So what is the most important thing you want to know about a fistula?
Sir,
What
whether
comes
it
in
is,
your mind?
so whether it is simple or is it complex?
One. And second, whether you are able to operate transvaginal, you will have to operate.
Yes.
Transvaginal or transabdominal. Yes, sir.
So that is just you will start thinking.
Yes, sir.
Correct?
Yes, sir.
Okay, fine. Yeah. Achin, go ahead.
Investigation.
Yeah, tell us. So what was the finding? Achin? There was a single fistula. We could see it on anterior
vaginal
vagina.
wall. Yes, a lower
Vagina.
anterior vaginal wall in the lower aspect.
And it was about, I think, 4 centimeter away from the 4.5 centimeter away from the external meatus. Correct?
Introitus. Yes.
Okay, fine. Okay. So now, just what you want to do?
Sir, now this is a recurrent fistula, as in the failed fistula repair. So before proceeding with anything, I will also first like to do imaging study to know whether there are any other communicated tracts and what is the current status of the bladder and the kidneys. So I would like to do a imaging study. Uh,
You
and
don't want to do basic test?
Yes, sir. First, I would like to do basic test like
Exam, understand. You please, you repeat it again and again. Every day
Yes, sir.
morning you repeat it.
Yes,
That
sir.
when any case comes, you will start with the even the malignancy, if you remember.
Yes, sir.
Only one or two extra tests you must say, but you must say that I will do urine routine, CBC, creatinine,
Yes, sir.
random
Yes, sir.
blood sugar. Okay, in this case, whether you want to do sonography or not, that is now if it is a primary case, then you will like to do sonography. But it is already established that whatever fistula she has got, then you
Yes,
are
sir.
not interested in finding out, and already DJ stents are there in CT, so you are not
Yes, sir.
interested. So in case you may omit sonography, and you can directly go for image. But
Yes, sir.
don't forget routine test.
Yes, sir. CBC create urine routine and urine culture. CBC to mainly look for the counts if there is any infection ongoing, systemic or systemic infection. Create for to decide about imaging and also the current kidney status, and urine routine and urine culture before proceeding for any intervention and to treat the infection primarily. Then I will like to do an imaging. In this case, I would, if the creat is normal and if the patient is willing, then I can go for a CT urography, sir.
Okay, so you want to do
I
CT
I would say do abdomen pelvis with urography.
Okay, I've done
Because
that.
we just discussed, you want to rule out about the bowel, where is it?
Yes, sir.
All
Yes,
the
sir.
laparotomy is done. Where is the rectum? Where is the vagina? What is uterus is removed properly or uterus is still there? Whether it is stuck.
Yes, sir.
So
Yes.
instead of just doing a urography is good, but you can say abdomen pelvis with urography.
Abdomen plus urography. Yes, sir.
Fine. So total proteins to find out the nourishment level of the patient, sir, whether she'll be able to
Yes.
withstand surgery or not.
Correct. So that we are going to say after once you see the imaging and when you are taking the patient, then you are going to talk about all the investigations.
I mean,
Fine. Okay.
yes.
Yeah. No problem.
So in this case, it differs a bit because here the patient has come to the OPD, sir is telling you that you do the CT and get everything ready. But when you will intervene, that will be another topic totally. Because
Yes, sir.
yeah, you understand. This is a VBF. You cannot just go in when all edema and this and that is there. So at that time, you will see the nutritional status, other investigation, everything,
Right.
fitness.
Right.
Okay. So these are the findings. Go ahead. Yes, you want to enlarge?
The other films are also there.
Sure. Yeah, just enlarge this. Who wants to describe?
Yes, sir. This is a CT scan of the abdomen plus pelvis and a urography study in which a delayed excretory images are visualized. Both kidneys appear normal. The contrast can be visualized in both the ureters till the lower part and into the bladder.
No, 1 minute. You are able
Yes,
to
sir.
see the contrast or only something else?
It's the digestion probably, sir.
DJ stent is also there.
Yeah.
Yeah, yes, sir. Yes, sir. DJ
So
stent as well.
multiple times we have discussed whenever you start any investigation, if you start with the X-ray, talk about its preparation, well centralized exposure, blah blah blah. When you talk about a CT scan, you start that this is abdomen and pelvis contrast with urography. Gallbladder, liver, spleen, pancreas are normal. Intestine, whatever you can see is normal. There is no extra free filled fluid, whether you see any lymph nodes or not. Then you come to urography, both the kidneys, blah blah blah. You go ahead. Don't miss that
Now
part.
Yes, sir.
Examiner should see that you have paid attention to all the details.
Yes, sir.
tell us very specific thing what you are able to see.
So there is a contrast till the lower part of the ureter. The contrast would be visualized, and then the contrast can be seen in the bladder also, and leaking into the vagina, which is filled till the upper to mid vagina. Uh, could be, and in one of the films we could see a connection.
Can you see the connection? Can you
Yes,
see
sir.
the
Yes, sir.
connection?
Yes, sir. On the right hand side of film, sir. Yes, sir.
You missed
Yes, sir.
one very
Yes.
important thing, air in the bladder.
Yes,
Air,
sir.
air.
Yes,
Air
sir.
hai na
There is
beta?
yes, sir. Yes, sir. Yes, sir. There is air in the bladder. Yes, sir. And we can see SPC also. And we can see the communication between the bladder and the vagina in the right hand film.
What are the causes of air in the bladder?
It could be one, sir, during SPC, during the
No.
procedure. Yes, sir.
Again,
In
go
general, I'm
systematic. It could
In
be,
general, I'm asking.
sir is asking generally. So what could be the causes of air in the bladder? Again, be systematic.
Yes, sir. It could be iatrogenic when the
No. First, post procedure, post catheterization, post
Yes, sir.
procedure cystoscopy.
Yes, sir.
These are normal causes. Then it can be iatrogenic. Third, it
Iatrogenic
can be
infections.
yes, communication with other organs.
Yes, sir.
Plastic
And fourth is infection, emphysematous.
Infection.
Yeah,
Emphysematous cystitis.
correct.
So what happens in rectovaginal fistula? I mean rectovesical fistula.
There can be air in the bladder. Yes, sir. That can
Why?
also be a problem.
Air in the bladder, what else? What will patient complain?
Pneumaturia, so there's pneumaturia.
Yeah, exactly.
Pneumaturia,
That
yes.
word should come.
Even
Yeah.
the feces, small pieces will be coming out. So now you tell me okay, why there is no leakage of urine? The bladder is above rectum. Na? Then why urine is not coming, leaking into the rectum, and patient is not passing urine per rectally? And why air is coming up? Yes, Rojas.
Uh,
Think
Yeah,
about pressure dynamics.
so rectal pressure is more than the bladder, so the air would be the
Why?
contents in the rectum would be going into the bladder.
Reason. Why it is higher?
The sphincteric mechanism of the rectum, so that is why there is no leakage. Sphincteric mechanism.
The air, because of the gas. The gases are under high pressure.
Pressure, yes, sir.
That is the reason you never get, unless and until it's a very big fistula, you
Yes, sir.
never get urine leaking. It is always the gas which is leaking into the bladder.
Bladder.
Okay, fine. So now this is a thing. So yes, Abhishek, what do you want to do now?
Sir,
What is next? Yes, Ojas, you can answer.
Yes, sir. So first, I would like to inquire now. The patient has an SPC in situ and bilateral stents in situ, and we want to know now how much was the discharge. Like after the removal of the SPC, she did complain of increasing the discharge again.
Is it going to change your treatment? They already put suprapubic catheter, and this patient is still leaking. Are you going to do anything new or something different by knowing this?
Sir is right. See, patient had a SPC removed, urine leaked. They put the SPC inside. Patient is still having leakage. No, patient has come to you. So again, stepwise, you say that, sir, I will, after seeing the CT scan, I will start with counseling of the patient. I will see how many days are over from the last surgery. I would
Yes.
allow this fistula to mature, give it time for the surrounding tissues to heal properly, and give adequate time. What is that adequate time?
So 6 to 12 weeks.
Correct. So about 3 months, 6 weeks to 3 months, you
12.
can say.
Yes, sir. Yes.
Yeah, 3 months if you
Come
wait
after
is
8
very
months.
good.
Yes,
Sorry,
after
sir.
8 months.
Huh.
Correct?
Sir, she has come after 8 months.
Yeah.
So sir is giving us the answer that she has come now after 8 months. So now you can say, okay, it is adequate time, plus the CT shows that all the other structures surrounding are clean. Kidneys are not hydronephrotic, stents are there. We have all the advantages. SPC is there. Bladder is filling up nicely, except for that communication with the vagina. Vagina is also showing the contrast. So it is good time now that you can counsel the patient, and you will have to explain that about the fistula repair and
Yes.
pre and post operative, what all management you will do. So go ahead like that systematically now.
Yes, sir. First, now we have done the imaging studies and we have done the blood investigations. So I will counsel the patient regarding the different surgical options for the management of such a fistula. Also, I will counsel her that since it is a
1
recurrent
minute.
fistula. Yes, sir. Yes, sir.
Ojan. 1 minute.
Yes, sir.
You will give her options.
Sir, you already mentioned it's a low fistula, sir. So
No. In vaginal fistula, will you give her an option? My question is very clear. Will you give, like there is a stone in the kidney, and you will describe about, you may talk about RIRS, you may talk about mini PCNL, URA, whatever you want to talk, ESWL. But in this case, will you give her option? She says, I want to go for a abdominal repair. Or she will say, I
So,
want to only vaginal repair. Now what will you do?
so the patient has undergone prior surgery, and so abdominal repair would be slightly
No,
more difficult.
yeah,
Yeah.
in this, see, every case, you should not talk only theoretically. Every case is different. So when you are talking about this patient, you have to talk about not in general. How you are going to counsel this patient. That is very important. Now this patient has already undergone one repair. So what are the chances of second repair being successful?
So with
The
every
first repair
repair
chances,
is
the first time, what are the success rate?
70 to 80%, sir.
Second time, yes, I think it is little more. Abhishek?
yes, sir, around 80% only, sir. And second time it comes down to 40-50%.
40-50%.
Correct.
So now in this patient, what is the first thing you will say? Now directly you want to go repair, or you want to do something else? Abhishek?
Sir, characterize the fistula and assess the nutritional status of the patient, sir.
No,
And
everything is there. My patient is now fit for surgery. She has come after 8 months, and then she is now fit. She has done everything.
So the patient has to be explained about that there are chances of failure of the fistula when it is going for a second surgery, that she might require an additional maybe a flap or some interposition for during the repair, and
Ojas, my question
yes,
is
sir.
very simple. Before doing fistula repair, will you do like to do something else? You don't want to see where is the fistula? What is the
Yes, sir.
relation with the ureteric
A
origin?
yes, sir. Yeah, characterize the
cystoscopy, do a cystoscopy, sir, and do a
So
cystoscopy.
why Question
We
number 2.
discussed it, still you guys forgot.
Yes, sir. We do a cystoscopy and then look for the location of the fistula, and in that we also assess the bladder capacity and the location of the fistula in relation to the ureteric orifices, and how large is
Tell
the
me all the features. Tell me all the important features of cystoscopy in this case.
the location of the fistula, the number of
First all, you
fistula.
go inside in a cystoscopy, what you will
You
see.
forgot the urethra. Bypass kar diya usko.
Yes, so first I'll assess the urethra,
Okay,
whether
you will
any.
see the urethra. Now,
Then we move on to the bladder neck. In the bladder neck, we also assess the relation of the fistula opening in relation to the bladder neck and the trigone area. Then the relation of the location, the number of fistula, relation to the ureteric orifices, the bladder capacity, and yes, sir.
bladder
This
capacity will be easy to measure.
no, actually, because no, sir.
How?
Bladder.
Then
Uh,
so you will like to see what is the condition of the bladder, whether it is
Bladder.
inflamed, there is infection inside
sir.
the bladder or not. Then you want to see the site of the fistula, size of the fistula, number of fistula, the edges of fistula, right or
Yes, sir.
wrong? Then
Yes,
it
sir.
is
Yes, sir.
nearness to the ureteric orifice, nearness to the urethra, whether it is supratrigonal or whether it is infratrigonal.
Yes, sir.
See, all these things you have to see.
Yes, sir.
Okay, and then the last thing is whether there are any foreign body inside, like
Yes,
your
sir.
thread, because she has undergone surgery. So whether
Yes, sir.
anything is there inside or not,
Yes, sir.
correct?
Yes, sir.
So suture, as the foreign body is the suture. So these are the important things. In one sentence, can you just tell me, starting from urethra, you just imagine that you are entering inside the bladder. So start from urethra and tell me.
The condition of the urethra, the location of the fistula opening from the urethral meatus, the bladder neck, the number of fistula, the edges of the fistula, the relation of the fistula to the ureteric orifices, whether it is supratrigonal or infratrigonal, the bladder condition, whether there is an inflammation, infection, whether there is any foreign body. Yes, sir.
The only thing you have forgotten is the size of the fistula. Anyway, then
Size, yes,
what
yes.
else is you can put a finger inside and you can see whether you are able to reach, whether your finger is able to reach to the fistula or not. Why I am telling
Yes.
you this is, some people do it. They do it to see if the finger is reaching up to the fistula, that means it is low enough and you can attempt for vaginal repair. You know,
Okay. Yes,
but
sir.
if it is
Yes, sir.
to reach to that fistula, then it is better to do transabdominal.
Yes, sir.
Understood? So this is just vague idea. I'm just telling you. So
Whenever
after
we are
doing this,
discussing instruments, we are discussing so much about 17 French sheath. For female cystoscopy. No, because of the special feature in the 17 French sheath, you can use it to see the urethra. So then you can
Yes,
change
sir.
it to 20 or 22.
Okay. Yes, sir.
This is a finer point, it will allow you to score, if you use your mind and what you are doing every day.
so okay, Abhishek, you like to do cystoscopy before or you like to do cystoscopy at the time of surgery?
Sir, cystoscopy can be done at the time of surgery also, sir.
No. What is in your hospital? What you are doing? You are doing at the time of the surgery or you are doing earlier?
So previously cystoscopy is done, sir. Characterization of the fistula is done, and biopsy is also taken, sir, at our center of the fistula, sir. And there
So
are
you can say in our institute we are doing this. However, in this case, you are right, Abhishek,
yes,
that you may do the cystoscopy and then immediately do the repair. Like sir said, the patient is 8 months, has undergone so much of agony, already surgeries are done. So in that case, you may make an exception. However, you can give your institution protocol.
I like to do, I'll just tell you, I like to do it before surgery only. The only reason is that I want to be comfortable. I want to be at ease. I want to see exactly if there are any multiple fistula, whether I have to put a glide wire and see, some opening is there or not. And if required, if they are near to the ureteric orifice, I like to put a digestate. At the same time, most important thing is if it is very near to the ureteric orifice, you have to do reimplantation of urethra.
Reimplantation. Yes, sir.
So it requires little longer time, you know. So you can plan out, like, you know, if you are just doing a vesico-vaginal fistula repair, it may take 2.5 to 3 hours. But if you are going to do reimplantation, if it is in the trigone, and you have to do bilateral reimplantation of ureter, again, little longer time, more morbidity, chances of complications are high. So you can explain it to the patient. So this is what our institute is doing, and that is what I am doing. But if your institute is doing cystoscopy just before surgery, like in pylography, for a few junction obstruction, is acceptable. You can always say, "Okay, in
Even,
our institute we are following these." Is okay, fine.
yes, sir, even
Yes.
in this is a complex case, sir. The RGP can also be done, sir, to characterize upper tract fistula, upper tract vaginal fistula, sir.
But
In
don't say
this,
that, because
no,
already two DJ stenting is done.
that's what,
Patient is.
not in this.
This case, I will say that I will also like to do earlier. The reason is what I want to change the DJ stent, because DJ stents are there since 8 months. There are chances that it may be infected, and I will like to change it. At the same time, I like to see the fistula, plan out my surgery, and then after good antibiotic cover, after 2-3 days later, I will take up a patient, because this you can do under local anesthesia also, or short,
Yes, sir.
less duration of general anesthesia. There is nothing like
Yes.
as a short GA. Anesthetist will not like it. Fine.
Right,
Okay.
sir.
You go on ahead. Okay, bye. Achin, can you show them?
Yes, sir.
Yeah.
This is the fistula, and in background you can see bilateral digestants. Okay. This much video is available.
Yes. Anyone can comment?
Sir, this fistula, sir, is sir, it appears to be between the bladder neck and the trigone, sir, and the edges of the fistula are, sir, looking non-inflamed. So, sir, the inference could be that this is a fairly matured fistula, and the size of the fistula appears to be around 4 centimeters, sir. And
No, it is not 4 centimeters. It is smaller. Just see again. Yeah, but see here you can see it little bigger. But
yes.
I think it is. Achin, it was what this thing about 1.5 5 to 6 millimeter, na?
Yes, sir.
7
In
millimeter.
CT they have mentioned smaller size, but it's a little bigger than what they mentioned in
It was
CT.
not more than 1 centimeter. It was
Yes.
not more than 1 centimeter. Right. So now what is your plan?
So, sir, it is far off from the bladder neck and it is far off from the ureteric orifices also. And the intratrigonal, sir, it is. And the size, sir, you mentioned 1 centimeter around, sir. So, and the edges of the fistula appear, sir, non-inflamed, sir, fairly mature fistula, sir. Sir, you can take her up for surgery, sir, in the form of a transvaginal repair, sir.
Okay. Ojas, you want to comment anything else?
So I will start with the findings first. So urethra appears normal, admitting scope with ease. The bladder neck is normal. The bladder wall appears normal. In the infratrigonal area, a 1 centimeter size opening of the fistula is seen. Bilateral digestant seen in situ. Bladder wall overall appears normal. The edges of the fistula are healthy. Uh, in this case, since the fistula is looking well mature and edges are healthy and it is infratrigonal, we can explain the patient about transvaginal approach for repair of the fistula, sir. With and since it is a recurrent fistula, I would also consider an interpositional graft or flap to enhance the success rate for this patient.
Okay, fine.
Uh,
What are the different, in general, I am asking you, what are the different ways of repairing the vesico-vaginal fistula.
Yes, sir.
Now,
So
question number 2. Will you like to do hysterectomy?
hysterectomy is, so regarding the first question, sir, I will answer first. Sir, different approaches for repair of a vesico-vaginal fistula are first trans-abdominal approaches and trans-vaginal. Trans-abdominal approaches could be suprapubic, intraperitoneal, or extraperitoneal approach, or it could be a trans-vesical approach.
Laparoscopic, robotic.
Yes, sir. It could be either open or open, laparoscopic, or robotic. In trans-vaginal approaches, there are one is the excision and repair. We have the Latchko technique, and we have the flap splitting techniques, in which with or without excision of the fistula, and with or without using interpositional graft material between the two involved organs. In the abdominal approaches, the O-corner approach is classic.
In trans,
Yes.
I just want to know, in trans-vesical, how
Yes,
will
sir.
you take the interposition of other structure?
Trans-vesicle, sir.
Yeah, trans-vesical.
Trans-vesicle, sir. We just suture it from the inside, sir.
So
We
you
can
said,
take
right?
trans-vaginal, we can trans-abdominal in the extraperitoneal approach, and intraperitoneal approach we can put interpositional graft. In trans-vesical, sir, we can't put interpositional graft.
So through the fistula only we can take the interposition, sir.
What you can take?
Sir, the Marshall's flap, sir. Marshall's labial fold flap, sir.
Trans-vesical, how will you take it?
Trans-vesical, we can't take it, sir.
Books have mentioned?
Trans-vesical, sir, we can't take the flap. It is suturing from inside. In cases of a smaller fistulas, we can suture the fistula from inside, sir.
Becomes very difficult. You cannot. Only thing is, I was seeing only one fellow doing it, that you can go superiorly and you can just pull between the vagina and the thing, a peritoneal fold, and you can bring it before you suture the. After suturing the vagina, you can put it, and you can, on that you can suture bladder. Only that much is possible. Okay.
Yes, sir.
Then second, you're doing fine. Go ahead.
So in trans-vaginal techniques, there is Latchko technique, and then there is Latchko, that is partial colpocolysis, and the flap splitting technique. In the Latchko technique, there is the fistula tract is the vaginal epithelium around the fistula tract is denuded, and then it is circumferentially excised with a 1 or 2 centimeter margin, and the tract is closed. Over that, another suture layer, and the perivesical fascia is closed over it. Whereas in the flap splitting technique, multiple 3 or 4 layers in which the vaginal flaps are raised. The fistula tract may be or may not be excised, and it may be closed with its margins, with its edges, and then over that the perivesical fascia is closed, and the vaginal flaps are closed over it.
Okay. So have you seen any time how to do it?
So I've only seen it once, actually, once.
Are you
I've not seen it, sir.
explaining, or you want me to tell you how to do trans?
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir.
So I will tell you what Shomo Raj is doing. Shomo Raj
Yes,
has
sir.
done probably more than 4,500, and all the complex, even fistula, he will like to do it transvaginal. So what he does
Yes.
is he got some special instrument like our what you say, mixture. Okay.
Yes,
So,
sir.
but this mixture is very pointed.
Hmm.
So what he does, he puts it like a dilator. He puts it inside the urethra and brings up into the anterior abdominal wall, and it just like a knife, it pierces and comes out. So he will open it up, take a 14 French Foley's catheter and pull it back inside the bladder. So now suprapubic is done. Okay,
Yes, sir.
because it is very difficult in cases of big fistula to fill up the bladder and do the suprapubic. Of course, I have done couple of times that even without this, you can just fill up the bladder and you can put a trocar and you can put it, but it becomes very messy and very difficult. So this is a very easy method. Within 4 to 5 minutes, his suprapubic is done in a female because they have got a small uterus. So now once the suprapubic is done, what he does is he makes this fistula a little bigger by putting the artery forceps or by putting a mixture inside that. And he will put 12 French Foley's catheter through the fistula and inflate the balloon, and he will pull it down. So what will happen? Anterior vaginal wall is brought into your vision. Now he will cut around the fistula. He will separate the vaginal wall, and superiorly he will separate even the bladder right up to the peritoneal fold, so that he can bring this peritoneal fold between the vagina and bladder. So now he will suture with interrupted stitches 30 vicryl. He will suture the bladder with 30 vicryl, okay, in a horizontal direction. So by that, he says two things are there, that vagina you are going to suture in a vertical direction, so they are not in the same direction. And second thing, there are less chances that ureter will come here. If you are suturing vertically, then both the ureteric orifice may come in your stitch. Okay, so here there are less chances. That is what he says. And after that, he will take 3 stitches perivesical tissue, like how you do in the thing, cystoscopy repair. So he will take this, on that he will put the peritoneum, and then he will suture vagina vertically with 20. So this is what he does.
Yes, sir.
Okay.
Yes, sir.
After suturing bladder and the perivesical, he puts a methylene blue inside, and you will see whether there is any leakage. And if there is any leakage, you will take one more extra stitch. So this is the important step. Right?
Yes, sir.
Okay. So tell me, one of you can tell me how to go about the abdominal. So abdominal, peritoneal.
Abdominal can be transperitoneal, sir, or sir extraperitoneal transvesical, sir. Sir, so in
really, we don't want to do much. We want to go directly to the intra-abdominal.
Yes, sir.
Peritoneal. You are doing transperitoneal because that is the most of the people they are doing this surgery.
Yes, sir. Sir, so sir, in transperitoneal procedure, sir, the only difference is the bivalving of the bladder is done and then the fistula is taken up, sir. Whereas in extraperitoneal approach, sir, we go behind the peritoneum and bivalving of we incise the bladder on the posterior wall, and from there, sir, the fistula is approached. That is the difference between the two, sir. And other than that, sir, the fistula repair is done in a standard procedure, sir. The fistula is the edges are excised and the interposition flap is taken, and first it is done layer wise and without in a tension free and watertight manner. And sir, yes, sir.
Can you just little elaborate the step? You have just given us a broad outline of fistula repair. The important step, just
Sir, after taking a lower abdominal incision, moving extraperitoneally, the bladder, we enter.
That means lower abdominal incision means what? From where to where?
So from just below the umbilicus to the pubic symphysis.
Why why want to go below the umbilicus and not above the umbilicus? Or I will put it in another way. Will you go below umbilicus or you'll go above umbilicus?
So below the umbilicus.
I'll give you a hint what sir is asking. Do you want to interposition something?
Yeah, so okay, we can go above, because if you want to interposition the omentum or the peritoneal flap, then we will have to go above the umbilicus. Yes, sir, from above the umbilicus.
See, already the complication has taken place, right?
Yes, sir. Yes,
So
sir.
you don't want to cause a problem. There may be adhesions, lots of problems. So
Yes,
better
sir.
to take a little bigger incision. Second
Bigger
thing is
incision.
you are going to take an omentum. Suppose omentum is short. Now what will do? Of course, you can always say that I will extend my incision and I will detach it from the stomach, greater curvature, and bring it down. That's okay. You can always do it. But why? Instead of that, normally it is mentioned that you go above the umbilicus. So
Okay,
you have
sir.
a big incision, good exposure in this complicated case, and you are going inside. Now, after once you have opened up, what are the things you are expecting?
So in this case, this is a recurrent one, so there will be multiple adhesions. We do adhesive lysis, then enter the space of.
Intestine also might have come right up to that, na, fistula.
Yes, sir.
Because it will come and it might be stuck there. So you have to separate it. Then
Separate
what else
that.
will be there? What is the most important history in this? Suppose the patient has undergone hysterectomy. What do you want to know? Oophorectomy is done or not?
Okay, sir.
What happens if the oophorectomy is not done? That also comes and gets adherent to that, and
Yes, sir.
everything is so much stuck that you are not sure whether you are dealing with the ovaries or whether you are dealing with the intestine. It becomes
Yes, sir.
very okay. So once you know it that ovaries are inside and you are expecting that ovary also might have come and there at the wound site and has got stuck, so you are not afraid. Correct? Okay,
Yes, sir.
fine. So these are the things. Second thing is the bladder. Even the bladder will be adherent to the anterior abdominal wall.
Yes, sir.
So you have to release this bladder.
Yes, sir.
When you are doing other simple cases, plain cases, all these things are not adherent. But here, if you don't do it, when you are doing the suturing of the bladder, when you bivalve it, it is okay. But when you want to suture, there will be a tension on that. So you must release it from the side and from the front.
Yes, sir.
Up to the bladder neck. Okay?
Yes, sir.
So this is the most important. Okay. Now what you'll do? So you release, you removed all the adhesions and you removed this thing. You separated the bladder. Next one.
Yes. Trace the ureters, mainly at the common area was the crossing, and trace it down.
You already put the digestant. Normally, it is better to put a digestant or uretic catheter, and at the end of surgery, you remove it. It is very helpful. So you don't have to identify the ureter, don't have to go there, you don't have to worry in your suture that you are going to take the uretic orifices.
Yes,
Okay?
sir. Then yes, sir. Then we enter the space of Regius, mobilize the bladder from behind. Then we do a posterior midline cystoscopy.
No. You're talking of cave of Regius. Cave of Regius. It is posterior or anterior?
Anterior.
Anterior, sorry. Sir,
I
we have
told you,
entered
you go right up to the bladder neck. You have separated the bladder.
Yes, sir. Yes, sir.
Okay, then.
Then we do a midline cystostomy, bivalve the bladder till the trigonal area, and identify the.
What we will
Yes, sir?
apply? Before that, you will apply the stay suture.
Stay sutures, yes, sir. Stay sutures over the bladder on both sides.
Which one?
Vicryl.
506070.
So we can use Vicryl 20 or 30.
Vicryl is very costly, 150 rupees, or I think more than that.
We can use silk then, sir. Silk 20 or 30. Silk 2030.
Yeah, you can take 30 or 20 silk. and you can take it.
Yes.
Someone has written down that if the fistula is very small, what will do? If the fistula is very small in cystoscopy, huh? Yes, some people I have seen it. What they do is they put a ureteric catheter over the glide wire and they pass it and they bring it out from the vagina. So that helps them in localizing the vesico-vaginal fistula. So that point also you can remember during cystoscopy. Fine? The
Yes, sir.
cannulization. Okay, fine. So go ahead. So you have taken the case suture. Now what will do?
Then a midline cystostomy, bivalve the bladder till the trigonal area and identify the
Trigon
location of the
area or
fistula.
till the no. If the fistula is above the trigon, then you will bivalve it up to the fistula.
Okay, so bivalve it up to the fistula. Yes, sir.
Okay. Then
Then identify the fistula, probe it, and look for the connection, and then either excision or we could mobilize the flaps from. Actually, this part, actually, I'm not very sure.
what do you do? I'll tell you. Once you
Yes,
have
sir.
reached to the fistula, now
Yes,
it
sir.
has become, instead of hole, it has become a U shape. Correct?
Yes, sir. Yes, sir.
Towards the urethra. So now you separate the vagina and the bladder. Okay.
Yes, sir.
So you separate it so that they both are at least 1 centimeter of the intact bladder and the vagina is there. So you can take a good suture. Understood?
Yes, sir. Yes, sir.
Where the distally, where the bladder and the vagina are uniting, that should be at least 1 centimeter away from the fistula.
Apart. Yes, sir.
Fine? You exercise the wall. I don't do it. I don't exercise it because our earlier the Campbell had not written down that. Now I think they are written it, so you can exercise it. So now what you will do? So first you will suture bladder or first you will suture vagina. Again, they say you suture horizontally. Sometimes it will be very difficult. So first you suture vagina. So you
Vagina.
take
Okay.
2 interrupted stitches. Okay, you can take 2 interrupted stitches, and then once you are convinced, then you tighten it and keep the thread long. Why
Yes,
want
sir.
to keep the thread long?
If you're gonna use the interposition graft, then to tie it along
Yes.
with it. Yes, sir.
See, now after you are convinced and you are happy that you have sutured your the patient's vagina well. Okay. Now
Yes,
what
sir.
you will do? Now you will start suturing bladder.
The bladder.
You will suture it with what?
So we will use a absorbable material, delayed absorbable material.
Which
We
one?
can use so we can use Vicryl, or we can use
Okay, you are using Vicryl. Which number?
so 2030, sir.
Normally 40, but some people are
40.
saying 30. 20 is
Okay.
too big because the
Okay.
needle is
Okay.
also too big, and that fistula you
Yes.
don't want. I use 40. And
Okay.
where will be the knot?
Outside.
Knot will be outside. Inside, then it will be an idus for bladder stones later on. So the knot should be on the outside.
Opposite. It is exactly the opposite. Actually, some people they say that it should be like in urethra. You know, latest you see, they are saying that knot should be inside because once it get absorbed, okay, it will
Okay, sir.
Right,
fall
sir.
out. It will come out in the urine. Okay. Here
Right.
they are
Okay.
saying if your knot is like you have taken 4 or 5 stitches, there is a knot. This knot can press over the fistula, niche, below that vagina.
Okay. Okay, sir.
So if they interrupt stitches, the first few knots they are inside the bladder. Now once you have taken, let's say about 2 to 3 centimeter of bladder, suturing is done. Now you do the interposition of omentum.
Omentum or peritoneum.
Peritoneum sometimes becomes little messy and difficult to bring it down. So momentum. So in 70% of the cases, momentum is coming there in 30%. But in for you, now I will say that 95% or 99% time the momentum will be. So
Yes, sir.
you take the
Okay,
omentum.
sir.
Suppose omentum is not coming there. What will do? Abhishek.
Sir, mobilize Marshall's flap, sir.
No, what will do to momentum? If it is a short momentum, what will do?
Sir, we would, sir, sir, we would like to, sir, the procedure I'm forgetting, sir.
That is from the greater curvature of the
Yes, sir. Yes, sir. Sir, the arterial arcade is made into a single feeding vessel, sir, and the pedicle of the omentum is then brought down to the operative site, sir, down below. I'm forgetting the name of that thing.
So now you have kept the long stitches. So what will happen? I put a needle on each stitch and at a different levels of the omentum from distally to proximally. I take the stitches and with opposite side, I just push that omentum down and tight with those 4 stitches which are taken over the vagina. Okay.
Right, sir.
Because after suturing, if you put momentum before suturing bladder, then it will be very difficult to suture bladder. And if you suture bladder and then you want to interposition, you want to do it, then momentum will not go right till the end to the apex of the wound. You understand? So that is
Yes,
why
sir.
you have to keep this thread long, so that very easily you can bring momentum down. Okay, so now you have sutured bladder with 40 up to some extent. Now what you do?
We do a leak test. So we fill the bladder with methylene blue and
Now
check.
you suture it. Huh? Now you suture it normally. The fistula part you already sutured with the 40 interrupted knots usually lying inside the bladder. Okay. Then now what you do? So now you'll start suturing the bladder, na? Like a
Yeah,
normal. You have the vesicostomy if you're done or you've just opened
yeah.
up.
We have yes, sir. 2 layers we suture the bladder.
No, not 2 layers, beta. Here you're suture only 1 layer. So above also
One.
1 layer.
Oh, okay.
So you will start suturing and that also like a continuous with a 20 vicryl, you can just suture it. Now once you are
Yes, sir.
coming up, before closing the bladder, what you
S SPC, sir.
you have to put the SPC. You have to
Yes, sir. Where to put the SPC?
Yes, sir. Alternative drainage.
So how will you put it? Which size?
So 16 or 18.
You like to put? You like to put a Foley's catheter or you like to put Mellicots or what you want?
So Foley's catheter.
How will you put Foley's? From inside out or outside inside?
Inside. Outside inside, sir. From
Outside in there is
outside
a
inside.
there is
Outside.
already a SPC there, sir.
Yes, the drain should always be from inside outside. But here in this case, now we have to bring it out, from outside to inside. So you will put
Outside.
your mixture
Inside.
in the bladder and then you bring it out from the bladder, then you bring it out from the muscle and skin and everything. Okay, and then you will bring the catheter
Yes, sir.
and put it. Now after that you will suture and then you will what about the polyurethral catheter? I don't know whether latest Campbell is saying or not, but earlier they were saying that balloon should not rest on the fistula repair.
Yes,
So,
sir. Sir, should not rest actually. Yes, sir.
so we apply a thread in the eye of the polyurethral catheter and bring it out from the side of the suprapubic catheter so that it is not resting totally
Okay,
on the fistula.
the fistula repair side. Yes.
Yes, sir.
So it is just lightly just resting on. Okay.
Yes, sir.
So now
Yes, sir.
you've done the fistula and now you've closed down. How many drains you like to put? And where you like to put the drain?
Sir, one extra peritoneal drain.
Surgery, after any bladder surgery, where you put the drain? After doing suprapubic cystolithotomy or you
One.
put it in the cave of Rhesus. Drain is always put, pre-vesicle is called cave of Rhesus. Always
sir.
put it there. Okay?
Okay, sir.
Yes, yes, sir.
In this case, because we have done the posterior repair, okay, so I put in the cave of Rhesus, I put corrugator, and behind I will put some abdominal drain, flat
Okay, sir.
drain.
Okay, sir.
Fine. So two drains
Okay, sir.
normally I like to put. Okay, and then
Yes, sir.
switch. So now post-operatively, how will you manage? What you will tell the patient that you have done the repair? Patient is saying, doctor, now I'm absolutely fine now. What will be your answer?
Sir, to avoid sexual intercourse for the initial 6 months, and sir,
I'm talking of day 1, day 2, day 3, day 4.
Said they would involve intraoperative and perioperative antibiotics, monitor the drain output. Then we will have continuous drainage of the urinary system through both catheters. The catheter should, before removing any catheter, we should do a imaging diet study to determine
Let
if
us
an injury is
be very let me ask you, what are the chances of failing the fistula repair, and when it will occur? First day, second day, third day, fourth day, fifth day, sixth day, 10th day, 14th day, 21 day.
failure of fistula, sir, usually manifests at around 14 to 21 days, sir.
No, it is always in the second week.
Okay.
It is always in the second week, and that is the reason you will not remove the drain. Okay, normally you should not remove the drain for at least 8 to 9 days.
Okay, 8 to 9 days. Yes.
8 to 9 days. And after that, nothing is coming after 8 to 9 days, then there are chances that it is not going to spill into the abdomen. Even if the fistula takes place, it will be directly going. But suppose if you remove it, after 4 days, there is no leakage or there is nothing coming in the drain, and you remove, there are chances that this urine will leak inside the abdomen also. So at least wait for 8 to 10. Okay, second week.
Yes. Yes. Sir.
Number 2, when you will remove suprapubic and when you will remove urethra.
So per urethral catheter should be at least kept for 10 to 14 days, and before removal, we should do a dye study to see if there is any leak.
See, many people say dye study. Suppose dye study, if you do under pressure, it leaks. Now what you are going to do? Are you becoming wiser by doing dye study? You just tell me. And in such cases, even if you put it little longer, what are the chances that fistula will not continue? So you can say that after 18 to 19 days or after 3 weeks, first you remove the perurethral catheter, okay?
Yes.
And then suprapubic you have kept it, so that you can keep it instead of perurethral, you can keep it in suprapubic. And see, if once the patient passes urine well for 48 hours, you can do suprapubic also.
Okay, sir.
Okay.
Right, sir.
What advice will you give? Yeah, post-op advice. What are the post-op advice you? Abhishek, you were telling us, no?
Sir, avoid sexual intercourse for the first 4-5 months. Avoid pregnancy for the next 1 year, and yes, sir, and preferable delivery. Preferable delivery method should be LSCS, sir.
Yes.
We could also prescribe anticholinergic medications to relax the bladder to prevent. That is one.
And this patient, someone has mentioned very rightly, timely voiding, most important thing.
Yes, sir.
Timely voiding, you tell them, and avoid infection. So routinely, they must do urine routine regularly.
Okay,
They
sir.
must and show you If there is any infection in urine, you are going to treat it.
Okay.
Okay.
Yes, sir.
If it is very near to the ureteric orifice, what will
So ureteric reimplantation may be required if it is very near to the ureteric
what type of
orifice.
reimplantation you will do?
Yes, sir.
What type of reimplantation you will do? Logical answer.
Sir,
Where you do
What do you do in transplant?
modified leech required, sir.
You are below, you are going to do the repair. Where you are going to do reimplantation there? Is it possible?
No, sir. Extra vesicle only.
That is the answer. No? You must.
Oh, yes, sir. Yes, sir.
Exam is more of the practical, what you have seen, number one. And second is your logical thinking. Everything you might not have seen, but if you start thinking very logical, then you can answer.
Yes. Yes, sir.
So you might have seen 10 different surgeries. And then when you come across some new surgery, with the help of those 10 surgeries, you will decide how to go for. The purposes of these clinics are also there. We are trying to show you as many cases, complications and everything, so that at the end you don't feel that I am not exposed, because nowadays I know that DNB and MCH, they are very specialized and there are subspecialties. So onco is going away, laparoscopy is going away, pediatric is going away. So all these things are going away from us, and we are not able to see each and every cases in them. So this is the way we are having some exposure.
Yes, sir.
Yes, sir.
So this is the way you should do reimplantation of ureter. Fine.
Right.
Yes, sir.
The notes you must write down everything, like in this patient, because when
Yes.
our uterus is intact, so if you have done reimplantation of ureter or any other omentum, you must write it down. So when they are doing cesarean section, they know it, because uterus is going to be behind this.
Yes.
Yes, sir.
Yes.
Normally nothing happens because they do the high LSCS most of the time, and and then because uterus is so big that over the period of 9 months it has displaced everything away. But once they know that ureter is anterior, omentum is there, they can plan out their surgery.
Yes, sir.
It is so important in every surgery. My own mama had a aortic aneurysm, and he was a case of post-transplant. And in the operative notes, they had written that they had done a end-to-side anastomosis of the renal artery. So they would have done definitely on the external ilet. So when they wanted to place a stent in the aorta, I had to warn them that be careful, there is a kidney and the graft is on the right side.
Okay,
So they could not take the Seldinger technique that side. So why OT notes are so important when in the future? So that's why sir is telling that if there is a implantation done, you have to inform the patient that the implant is like this, ureteric reimplant.
Got it, sir.
Yes, sir.
Yeah. So now anything is left? Anything? Any questions?
By repeated presentations, you are doing very well, Abhishek. I'm liking it.
Thank you, sir.
And it is becoming systematic. And I feel that
Yes, sir.
you've
Yes,
done
sir.
well.
Yes, sir.
But
Yes, sir.
but all of you have to learn from Abhishek. He's always proactive, coming in upfront to present.
Yes, sir.
So all of you should start taking that. Make as many mistakes as you want here. We are teaching you like you are our own. So don't
Yes, sir.
hesitate. Make mistakes. It's okay to make mistakes here.
Sir,
But at
one
the
more
end,
question I'd like to ask. Hi, Hiren, I would like to interrupt here.
yes.
This is Dr. Rajkumar. Yeah. Hello.
Hi, Rajkumar. How are you?
Yeah, fine, fine.
Good.
Say if there is a leakage after, say, 2 weeks in the repair and a slight leakage, then how to go about it?
See, the best thing is that if you wait for about 7 to 10 days and if the leakage stops, then you consider that and do it, keep it for another 2 weeks. Like for example, you have come across a case after hysterectomy. 10 days later, patient has got a leak, and you put a
Yeah.
Foley's catheter. And then after 24, 48 hours, that leak stops because it
Yeah.
is a small fistula. So then you tell the patient that you keep this catheter now for 21 days, let the healing take place. The same way here also, we should do the same thing. And if possible, if the suprapubic is draining very well,
Yeah. Yeah.
then only then you can think of removing the polyurethral catheter, because that might be causing some pressure effect on the fistula. But at least for next 8 to 10 days, if it is draining well and there is no leakage, just wait. Just wait.
Okay. Yes. Thank you, sir.
Alright. So nice. We are coming to Sumerpuram.
Yeah, we are coming to Sumerpur.
Yeah. When you are reaching, sir? 31st.
29th, we are leaving.
Okay. Okay.
So 30th, 31st, we are doing the camp.
Sure.
If
Sure.
you are
I'll join
free,
you
come.
there on
It will
30th.
be great. Yeah, it will be great
Yeah,
to see
I'll
you,
join
sir.
you. I'll join you there at 30th.
It'll be
Rahul sir
great
had
to see
told
you.
me. So
It is good
I'll.
to see you on these clinics also.
Yeah. Yeah.
So for
Thank
everybody,
you.
me and Dr. Rajkumar are sir's students.
The sir has always been a guiding force
Yeah, yeah.
and motivating force for us.
Gaurang Shah sir is our teacher, and now
Yeah.
we are teaching you. So pay it forward, all of you.
Yes.
Thank you. Thank you, sir.
Now question number, just put it in the group that next week we are having this thing, a USI conference.
Yeah.
Okay.
Yes,
so,
sir.
Weekend only. So we are having USI conference. Whether you want to have a class next Tuesday or you want to postpone it for 1 week. So just put it on a group or tell Tanvi. So let us see. Okay.
Okay,
Yes,
sir.
sir.
Thank you, sir. Thank you.
Achin, just coordinate with Tanvi madam
Yes, sir.
and see what we have to do. Okay.
Okay, sir.
Yes, sir.
Bye.
Good
Good
evening,
night,
sir.
everybody.
Good
Yes,
evening,
sir.
sir.
Sorry, you
Thank you,
want
sir.
Thank you, sir.